Okay, good morning, everyone. Bonjour tout le monde. Bienvenue à notre conférence de presse. My name is JP Tasker from CBC News, and I'll be the moderator for today's press conference. Today, we have Dr. Theresa Tam and Dr. Howard Njoo from the Public Health Agency of Canada, who are obviously no strangers to us all. They're here to provide an update on COVID-19, and they'll also be available to take your questions on monkeypox. Okay, doctors, the floor is yours. À vous la parole.
Bonjour à tous. We're actually providing a technical update on monkeypox, but of course we'll be happy to take other questions. Donc, bonjour à toutes et à tous. We are here today to provide an update on our efforts to address cases of monkeypox in Canada. The Public Health Agency of Canada is closely working with international, provincial, and territorial partners to keep Canadians safe. We are closely monitoring emerging data, and as we learn more, our response and advice will continue to evolve. Over the past week, the Public Health Agency of Canada has confirmed a total of 112 cases across the country. This includes 1 case in British Columbia, 4 in Alberta, 9 in Ontario, and 98 in Quebec. Among cases for whom information is available, age range from 20 to 63 years. All cases to date are male, and the majority report having sexual contact with men. However, this virus can spread to anyone through close contact with an infected person. The National Microbiology Lab, or NML, is also performing confirmatory testing on a number of other suspected cases. Therefore, we are preparing for more confirmed cases in the coming days and weeks. In addition, the NML is conducting sequencing of the virus causing Canadian cases. Early results indicate that cases in Canada are related to the international outbreak. Further work is being done to better understand chains of transmission domestically in support of the ongoing outbreak investigation. Working together with provinces and territories, our primary goal is to contain the outbreak. This means rapidly stopping chains of transmission to prevent the establishment of monkeypox in Canada and protect public health and healthcare in Canada. We're also focused on protecting those at the highest risk of severe outcomes, including immunocompromised individuals, pregnant people, and children under 12 years of age. In support of this approach, today, the National Advisory Committee on Immunization, on NACI, released new recommendations for the use of Imvamune, a Health Canada-approved vaccine for immunization against monkeypox. After reviewing the data on the current status of the monkeypox outbreak and evidence on the safety and protection offered by the Imvamune vaccine, NACI recommends a single dose of Imvamune may be offered to individuals with high-risk exposures of a probable or confirmed case of monkeypox, or within a setting where transmission is happening, ideally within 4 days of exposure. Affected provinces are currently implementing vaccination strategies based on their local epidemiology. And the Public Health Agency of Canada is currently working with manufacturers to ensure sufficient vaccine supply moving forward and planning with partners to ensure we are equipped to respond effectively to the evolving situation. At this time, a mass vaccination campaign is not needed to address this outbreak in Canada. We have also been developing guidance to support public health and healthcare providers across the country. This includes interim guidance on infection prevention control for suspect, probable, or confirmed monkeypox within healthcare settings, as well as guidance on public health management of cases and contacts. We have met with and continue to engage with stakeholders to help raise awareness of the outbreak and reach communities that may be more at risk with information to help them protect their health and that of their loved ones. With the summer around the corner, people in Canada are gathered for festivals, concerts, and celebrations. Now more than ever, we need to equip individuals with the information they need to plan how they can celebrate safely and reduce their risks of contracting and spreading illness. I want to remind everyone that monkeypox is not limited to just one community. The virus can spread to anyone through close contact with an infected person or their contaminated objects. We continue to ask that all healthcare providers in Canada remain vigilant and closely watch for patients with any symptoms of monkeypox, even atypical presentation, regardless of whether they have reported travel. If you have been in close contact with someone with monkeypox or you develop symptoms like a new rash or sores on your skin after you had sexual activity or close personal contact with others in the last 21 days, please contact your local public health unit and they will give you instructions on what to do next. As we learn more about the virus, we will continue to provide regular updates to ensure those in Canada have the information they need to stay safe. Information is also available on canada.ca/monkeypox. Thank you. Merci. Megwich.
Bonjour à toutes et à tous. Nous sommes ici aujourd'hui pour faire le point sur les efforts que nous déployons pour lutter contre les cas de variole simienne au Canada. L'Agence de la santé publique du Canada travaille en étroite collaboration avec ses partenaires internationaux, provinciaux et territoriaux pour assurer la sécurité des Canadiens. Nous surveillons de près les nouvelles données. À mesure que nous en apprendrons davantage, notre réponse et nos recommandations continueront d'évoluer. Au cours de la dernière semaine, l'Agence de la santé publique du Canada a confirmé un total de 112 cas au pays. Ce nombre comprend 1 cas en Colombie-Britannique, 4 en Alberta, 9 en Ontario et 98 au Québec. Parmi les cas pour lesquels l'information est disponible, l'âge varie de 20 à 63 ans. Jusqu'à présent, tous les cas déclarés sont des hommes et la majorité d'entre eux ont déclaré avoir eu des rapports sexuels avec d'autres hommes. Toutefois, le virus peut se transmettre à n'importe qui à la suite d'un contact étroit avec une personne infectée. Le Laboratoire national de microbiologie, ou LNM, procède également à des tests de confirmation sur un certain nombre d'autres cas suspects. Ainsi, nous nous préparons à la confirmation d'autres cas dans les jours et les semaines à venir. De plus, le LNM procède au séquençage du virus entraînant les cas au Canada. Les premiers résultats indiquent que les cas au Canada sont liés à l'éclosion à l'échelle internationale. D'autres travaux sont en cours pour mieux comprendre les chaînes de transmission au pays et appuyer les enquêtes sur les éclosions actuellement réalisées. Travaillons de concert avec les provinces et les territoires. Notre objectif principal est de contenir l'éclosion. Pour ce faire, nous devons rapidement interrompre les chaînes de transmission pour empêcher l'établissement de la variole simienne au Canada et protéger la santé publique et les soins de santé au pays. Nous nous concentrons également sur la protection des populations à plus haut risque au Canada, notamment les personnes immunodéprimées, les femmes enceintes, les enfants de moins de 12 ans. Pour appuyer cette démarche, le Comité consultatif national de l'immunisation, ou CCNI, a publié aujourd'hui de nouvelles recommandations concernant l'utilisation d'Imvamune, un vaccin approuvé par Santé Canada pour l'immunisation contre la variole simienne. Après avoir passé en revue les données sur la situation actuelle de l'éclosion des varioles simiennes, ainsi que les preuves de l'innocuité et de la protection offerte par le vaccin Imvamune, le CCNI recommande qu'une dose unique d'Imvamune soit offerte aux personnes présentant un risque élevé d'exposition à un cas probable ou confirmé de variole simienne, ou se trouvant dans un milieu où la transmission se produit, idéalement dans les 4 jours suivant l'exposition. À l'heure actuelle, les provinces touchées mettent en œuvre des stratégies de vaccination fondées sur l'épidémiologie locale. L'Agence de la santé publique du Canada travaille actuellement avec les fabricants pour garantir un approvisionnement suffisant pour s'assurer que nous disposions des ressources nécessaires pour bien répondre à l'évolution de la situation. Pour le moment, une campagne de vaccination de masse n'est pas nécessaire pour faire face à cette éclosion au Canada. Nous avons également mis au point des lignes directrices pour aider les services de santé publique et les prestataires de soins de santé dans tous les pays. Il s'agit notamment des lignes directrices provisoires sur la prévention et le contrôle de l'infection en cas de variole simienne suspecte, probable ou confirmée dans les établissements de soins de santé, ainsi que les lignes directrices sur la gestion des cas et des contacts par la santé publique. Nous avons rencontré les intervenants et continuons de collaborer avec eux afin de les sensibiliser à l'éclosion et de fournir aux communautés les plus à risque des renseignements qui les aideront à protéger leur santé et celle de leurs proches. À l'approche de l'été, les Canadiens se retrouvent à l'occasion des festivals, de concerts et des célébrations. Maintenant, plus que jamais, nous devons fournir aux gens les renseignements dont ils ont besoin pour planifier la façon dont ils peuvent célébrer en toute sécurité et réduire le risque de contracter et de propager la maladie. Je tiens à rappeler à tous que la variole simienne ne touche pas qu'une seule communauté. Le virus peut se transmettre à n'importe qui par contact étroit avec une personne infectée ou ses objets contaminés. Nous continuons de demander à tous les fournisseurs de soins de santé au Canada de rester vigilants et de surveiller de près les patients présentant tous symptômes de la variole simienne, même une présentation atypique qui rapporte ou non avoir voyagé. Si vous avez été en contact étroit avec une personne atteinte de la variole simienne ou si vous présentez des symptômes comme une nouvelle éruption cutanée ou des plaies sur la peau après avoir eu une activité sexuelle ou un contact personnel étroit avec d'autres personnes au cours des 21 derniers jours, veuillez communiquer avec votre bureau de santé publique local qui vous indiquera la marche à suivre. À mesure que nous en apprendrons davantage sur le virus, nous continuerons de fournir des mises à jour régulières afin que les Canadiens disposent des renseignements dont ils ont besoin pour rester en sécurité. Ces renseignements se trouvent également à l'adresse canada.ca/variole du singe. Merci. Thank you. Miigwech.
All right, thank you, doctors. We'll now turn to the question period part of this. Participants who are online, please raise your hands using the raise hand function on Zoom, and we'll work our way through the list. Our first question this morning is from Rachel Haynes at CTV News. Please go ahead.
Hi, doctors. Rachel Haynes here from CTV National News. Thank you for the update on monkeypox, but my questions are actually related to COVID-19 and our current mandates that are in place right now. And my question to you is, do you think that there still needs to be vaccine mandates in place for travel in Canada?
Well, as I've said before, I think the relevant ministers are looking at those mandates as we speak. We are providing information to support their decision-making. And I think I would ask that you go back to the relevant departments on their decision-making process.
Follow up, Rachel?
Thank you, Doctor. But I would love to know a little bit more about this information and the advice that you're providing to these relevant ministers. As Canada's Chief Public Health Officer, is there a justification for keeping vaccine mandates in place? Or can you tell us what is the advice, the public health advice that you are giving to these ministers?
Well, I think first of all, I would want to remind everyone that the people in Canada have done extremely well in, I think, taking up vaccinations. The vaccine mandates or requirements, as they were enacted late last year, were implemented at a time when this was pre-Omicron, where the Delta variant was escalating with some serious signs of serious outcomes. And I think at that time, there was a very good vaccine effectiveness against both infection and therefore likely transmission and against serious outcomes. When Omicron emerged, I think that changed the landscape for COVID-19. That is to say that we're very grateful that the vaccines are still very effective against serious outcomes, particularly after a booster. And that third dose is actually important, but it still works really well. I think what the data being examined is the vaccine effectiveness against infection and potential risk to people in workplaces and in the travel corridor. And so the data has been presented, and I just want to clarify that 2 doses is not enough to provide vaccine effectiveness against Omicron infection, and because the immunity wanes after about over time, and certainly by 6 months. So you need a booster or a 3rd dose rather to be to bring that immunity back up. And the vaccine effectiveness against infection is modest, but it's not nothing. I think that's something that people have to bear in mind. It's around, depending on the study, it's around 50-60% if you get boosted, and it will wane over time, and we're just monitoring that at the moment. So all of that scientific information is taken into account, but that's not the only consideration that the relevant employers or the ministers have to take into account. And given that vaccines are imperfect, though still provide some protection against infection and transmission to others, there are layers of protection that are still needed, such as masking. So they can't just make one singular decision. They have to look at the suite of protective measures to keep employees, workplaces, and the travel corridor as safe as we can. The other advice I think we give is pertaining to the domestic and global epidemiology. And right now we are on a better trajectory in terms of the cases and hospitalizations, but many hospitals still have a lot of patients with COVID, and we are still experiencing quite a number of deaths per day. So it's still very much with us, the pandemic, but we are in a better state in terms of epidemiology. And globally, I think it's unpredictable. The global trend is down in terms of epidemiology, in terms of the cases, and that's great. But as you can see, other variants are emerging. The situation can change, and we need to prepare for sure towards the fall and winter period. So it's not an easy decision to make, but I think those are the relevant kind of data that it can be provided, including also the coverage right now for the booster dose. They'll take all of that into account as they're making their decisions.
Okay, the next person on my list is Laurence Martin, Radio-Canada. À vous la parole. Laurence, I think you have to unmute yourself.
All right. Can you hear me now?
Yes, we can. Go ahead.
OK, great. Bonjour, ma question est pour le Dr. Njoo. Sur les tests aléatoires aux frontières, j'essaie juste de savoir, disons qu'on est un voyageur canadien et qu'on rentre au pays là, en ce moment, combien de jours après notre arrivée à l'aéroport, il faut que le test soit fait pour qu'il soit efficace, pour qu'on puisse détecter le virus avant qu'il ne se propage dans la communauté?
Merci pour la question. C'est une bonne question et je peux vous dire que on est toujours en train d'analyser les dernières probantes, aussi la science qui continue à évoluer. Ce que je peux vous dire que on est en train encore de peut-être faire des recommandations aux décideurs, peut-être concernant le programme de dépistage aléatoire aux frontières, parce que il y a toujours des choses qu'on peut faire pour rendre le processus plus efficace. Donc, je pense, pour répondre à votre question, c'est une question de peut-être, OK, est-ce qu'il y a d'autres moyens? Peut-être c'est pas nécessairement à l'aéroport, peut-être on peut faire ça peut-être ailleurs. Donc, c'est toujours une question, pas nécessairement pour prévenir la transmission, comme peut-être vous avez constaté avec votre question. Mais c'est aussi une couche de protection parce qu'ici, c'est un moyen pour surveiller s'il y a peut-être l'émergence d'un variant préoccupant. On peut faire quelque chose à la frontière, mais aussi au sein du pays parce qu'avec les séquençages, on est toujours prêt à détecter peut-être un variant préoccupant. Donc, si votre question c'est quand le bon moment pour faire un dépistage à la frontière pour empêcher la transmission, on sait que même avec les vaccins, ils sont très efficaces. C'est sûrement que 3 doses, c'est plus efficace comparé à 2 doses pour se protéger contre les conséquences graves. Aussi, peut-être pour un bout de temps contre l'infection, mais ce n'est pas à 100%. Donc, c'est toujours une possibilité de même transmettre aux autres personnes. Donc, c'est très important d'utiliser des autres couches de protection, comme le port de masque. C'est peut-être maintenant une décision personnelle. Donc, ça, c'est le rythme et on continue à continuer à évaluer et aussi donner des recommandations aux décideurs pour toujours avoir une amélioration de système de dépistage à la frontière, mais aussi au sein du pays. Merci.
Oui, mais Monsieur Dr. Njoo, je m'excuse, mais ce n'était pas ça ma question. Moi, je voulais juste savoir, il faut que le test il soit fait combien de temps après l'arrivée? Parce que on a un exemple, par exemple, où ça fait 2 semaines que des passagers attendent de faire leur test après l'arrivée. Est-ce que 2 semaines après l'arrivée, c'est trop tard? Est-ce que le virus s'est déjà propagé dans la communauté? C'est ça que je veux savoir. Combien de jours après l'arrivée il faut que ce soit fait, le test?
OK, donc peut-être je n'ai pas bien répondu, mais je m'excuse. Moi, je comprends que oui, c'est toujours idéal de faire le dépistage le plus tôt possible après l'arrivée si on est choisi pour le dépistage aléatoire, peut-être dans quelques jours. D'après moi, sûrement quelques semaines après l'arrivée, ce n'est pas idéal. Mais par contre, comme j'ai déjà constaté, même si on fait le dépistage tout de suite après l'arrivée ou même après, c'est toujours important pour les personnes qui arrivent au Canada de continuer d'utiliser des bonnes pratiques de protection individuelle pour se protéger, mais aussi peut-être si jamais ils sont peut-être contaminés, infectés, pour peut-être limiter ou diminuer le risque de transmettre le virus aux autres. Donc, je pense que ça, c'est la réponse que vous cherchez. Oui, quelques semaines après, ce n'est pas idéal, mais par contre, c'est toujours une question de continuer d'utiliser des bonnes pratiques de protection individuelle. Si c'est tout de suite après l'arrivée ou même 2-3 semaines après l'arrivée.
Elizabeth Thompson, CBC News, you're next.
Thank you very much. I'm going to return a little bit to the first question you were asked about, because there has been a lot of debate in the House of Commons about vaccine mandates and being lifted for travel, both domestically and internationally. How comfortable are you with the idea of those vaccine mandates being lifted? Because as you mentioned, there are a number of factors the government will have to weigh, but I'm wondering what you are thinking.
Well, I think at the time vaccine mandates were put in place, we were not absolutely certain how effective they would be. After they were announced or around the period that they were put in place, there was an increase in vaccine coverage, somewhere between 5 to 8%. But at the same time, the provinces and territories also had their requirements for vaccines. So I think the effectiveness could be different at this point in time. Personally, I think that we have to do all the other things that supports people to get vaccinated and reduce transmission. For example, there's many reasons why people haven't got up to date with their vaccinations, and we need to do all the other things. When decision makers consider mandates, they're but one tool for increasing vaccine coverage. We have to understand why people are not getting up-to-date vaccinations and address those gaps and questions, including access, including the understanding of why it's important to do so, and answer the questions, and also do appropriate empowerment of the communities and the trusted leaders. All of those things that we, I think, very successfully did in the initial vaccination campaigns, give a pat to all Canadians, have to be put in place too. You can't just have something like a vaccine mandate working on its own. And so I think it's important to look at all the other measures.
When you do look at the various measures that are across the country in terms of public health restrictions, are there any that we don't need anymore that could be lifted, or are there some that people are lifting that you think should stay in place?
As I said, we're in a bit of a transition period. We know what works. Vaccines are important, and getting up to date with vaccination is important. And adding on top of that layer of masking does work. The question is whether they should be required versus a recommendation. And I think quite a few weeks ago, I said, this is going to be a difficult transition period. There'll be many people who think, well, without some requirement, people won't know what to do. And I am immunocompromised. I want other people around me to be protected as well. I feel much safer as a result. But at the same time, one has got to get a better balance and transition to a point where we are empowering the public to think of masking and vaccination as a regular personal protective behavior or routine. So wearing a mask this coming fall and winter, I think people should think of as routine practice. But the transition from requirements to recommendation is going to be a tricky one and may not happen all at the same time or in the same similar manner because populations are different. I think chief medical officers across the country are trying to think through this transition with their own particular communities in mind. But for federal government, they have a very different set of communities or populations, not the least of which is the rest of the world and what's happening there as well, and trying to protect the domestic epidemiology and domestic health systems. So there's different dimensions to that decision making. But I do think what we're seeing and all your questions are related to this rather difficult transition.
Okay. Marie Vastel, Le Devoir.
Hi, I'm going to continue on that, Dr. Tam, if that's okay. I wanted to also circle back to what you said earlier. You mentioned that the 2 doses isn't enough anymore, and effectiveness, even with the booster, is, I think you said 50 to 60%. Can you tell us what the percentage of effectiveness is for 2 doses of vaccine? And in that following that, if you're saying it's not enough, and I suspect the level of effectiveness will be less than 50, 60% for 2 doses, are you recommending to require then 3 to 4 doses, or to just perhaps, as you said, go through this transition by encouraging instead of requiring 3 to 4 doses?
Yes, so the vaccine effectiveness question is quite complicated, so I'll try and unpack that. There's vaccine effectiveness of 2 dose or 3 dose or more against different outcomes. So vaccine effectiveness against infection and onward transmission, as well as vaccine effectiveness against the more serious outcomes. And so we know that with the prior to Omicron, 2 doses of vaccine were highly effective against getting infected. Even with the arrival of the Delta variant, there was some diminution over time as well, but still really quite good. And the 2-dose vaccine effectiveness against serious outcome at the time was very good. But with the arrival of the Omicron variant, that changed things because it's immune evasive. The spike protein is so different from the previous variants that changed the epidemic dynamics. And so you're seeing much more transmissible virus. Vaccine effectiveness for 2 doses waned over time, so that by the time you're about 6 months out or more from the 2-dose vaccination, that you have very little protection against infection. But still, there's significant protection still against serious outcomes. With a 3rd dose, you boost your vaccine effectiveness against infection. Depending on the study, the population studied somewhere around the 50 to 60% mark soon after you get that third dose. We're monitoring right now how that effectiveness diminishes over time. Now, remember that for some other vaccines, such as influenza vaccine, something like a 50% or over vaccine effectiveness, we would be overjoyed. So it's nothing, but it does diminish over time. But 3 doses boost your immunity against serious outcomes to over 90%, which is why, together with the chief medical officers, the National Advisory Committee on Immunization, we're really focused on trying to get people up to date, including additional doses, depending on age group, your 4th dose as well, at this point in time. And so I think that's the concept people have to begin to understand. I think towards the fall, we'll be looking at the potential for an increase in activity, and immunization programs across Canada are gearing up to support Canadians to get vaccinated at that time. So that's just the foundational background to answer your question. And I think, as you've seen in many jurisdictions, vaccine requirements have been lifted, and asking people to get up to date and do the thing that will protect them and their families. I think the federal government is now having to examine whether mandates will have additional benefit or whether there should be a shift in posture. So that is, as I said, actively being examined by the relevant ministers.
It's Dr. Njoo.
Can I just, because this really, I'm sorry, Dr. Tam, with all due respect, it didn't answer my question with facts and the statistics that I was asking. And I feel like I'm going to lose my follow-up by repeating my question. If I can get a follow-up, that would be great, though. What I'm trying to understand, you have a percentage for the effectiveness after a 3rd dose with Omicron. I would like to know, I know that it wanes after 2 doses after 6 months. What I would like to know is, do you have a percentage of effectiveness after 2 doses and presumably over 6 months at this point for most people? Because the current vaccination mandate is 2 doses. I'm trying to assess what the effectiveness of those 2 doses is right now with the current mandate. And then the second part of my question was, I understand the decision is up to the relevant departments and ministers, but as the Director of Public Health, do you believe that it should be required to up to 3 or even 4 doses to follow the need for effectiveness? Or do you privilege or privilegiate, or do you prefer the approach of encouraging people to get a vaccination, as you said, might be where we're heading with this transition?
Yes. So I thought I answered your question, but maybe I'll repeat it. So after 6 months with 2 doses, the vaccine effectiveness against Omicron is very low.
Yeah, but you have a percentage.
There's so many studies and they're variable, but 20% or less, I would say.
Okay.
Yeah.
Right? So there's almost no protection from infection, but still quite a good protection against severe outcomes. And I think, and that diminishes over time, but really still quite robust. I think people have to remember that the first 2 doses are the most important doses of the vaccine series.
Do you have a percentage, for the outcomes? Because I'm really asking you for numbers. I appreciate the ones for...
I will give you the outcomes.
Thank
2
you.
doses, Omicron, with vaccine effectiveness shortly after the last dose for 2 doses is 50 to 80% within the first month, diminishes to about 20% or less after 6 months. Okay. Severe illness, 65 to 85% range, very wide range, depending on the study and the population and the age, etc. But pretty good. For 3 doses, your starting point is about 50, 60, 60%. Again, a range, 40 to 80% in the initial studies. It will decline over time, but we haven't got enough data points at this moment. We expect that to come down. For severe disease, it's over 90%. for the third dose. Now, it may diminish over time. A variant could come along, BA4, BA5, that could reduce the effectiveness as well. So it's never a static number. It's going to have to be watched over time. Is that clearer?
Yeah, it's
Yes,
Dr. Njoo.
Thank you very much for the numbers. I appreciate it. And if you could tell me if now you think we should up the mandate to 3 to 4 doses or just transition to recommendation, that would be great.
So I think together with the Chief Medical Officer, we already recommended that people should get up to date. So that is our bottom line recommendation, is depending, of course, on your age, your risk status, and according to the recommendations of NACI, we're going to give this a push towards the fall as people gather and resume full activities. So that is really my position. And mandate is a policy decision that takes into account many different factors, and it's up to the policymakers at this time to make that difficult decision. But I would always be going with recommending up to date. The difficulty, I think, right now is that the federal definition of vaccine mandates is for administrative or travel or other purposes is not up to date. And I am encouraging everybody to adopt the definition, however they look at the policy, to reflect the up-to-date need to have the best protection.
It's Dr. Njoo. Maybe I could just add some additional points to what Dr. Tam has already said. You know, as she said, the whole issue of immunizations, the number of doses is complex. And I would say that we can't just focus, quote, on the number of doses that any given individual has received. For example, if you receive 2 doses early in 2020 with a very short interval, I would say that your protection certainly is not the same as someone who received their 2 doses later with, let's say, a longer interval, let's say 8 weeks or more. So it's not as straightforward in terms of just the number of doses. The other point that Dr. Tam has said, I would repeat, is that yes, because there are different individuals, populations with varying levels of risk, it's more important to not focus specifically on, you quote, the number of doses, but remaining up to date with your vaccination, obviously also depending on local context, so that you have the most or up-to-date protection possible. And certainly we've seen that a third dose certainly is very helpful. It certainly gives a good protection, but we've seen over time that the vaccines, in terms of overall protection at a population level, even for individuals, starts to wane, and is maybe after 6 months, that's when maybe is an ideal time to get that third dose. The other point, though, is that I think Dr. Tam and myself and public health officials, ideally, in a perfect world, we want to increase vaccine coverage, right? And the great way that I think Canadians have responded to making an informed decision based on the science and getting good information so that they understand why it is good for themselves and their loved ones to get vaccinated. I think that's the ideal way. If you talk about mandates, that's certainly, quote, another tool in the toolbox, and that's something that certainly the decision makers also use to varying degrees as a policy option. But that's different from, let's say, the public health perspective, where we really want vaccine coverage as high as possible. And ideally, it's always with sort of an informed decision that people really see that there's benefit for themselves and for others. Thank you.
Okay, thank you. Mylène Crête, la presse.
Bonjour. Je voulais savoir, êtes-vous prêt à la santé publique à recommander la fin des tests aléatoires pour les voyageurs par avion, comme les États-Unis viennent d'appliquer cette politique?
C'est Dr. Njoo. Merci pour la question. Oui, je pense que c'est toujours une évolution, comme je pense que j'ai déjà constaté avant. Qu'est-ce qu'on fait à notre frontière avec maintenant le système avec un dépistage aléatoire? C'est une autre façon de surveiller peut-être pour des variants préoccupants qui sont émergents peut-être ailleurs à l'étranger, ou c'est aussi possible au Canada. Donc, il y a aussi des autres moyens. C'est pas la seule façon de détecter, d'être capable de trouver des variants préoccupants. On continue avec le dépistage même au sein du pays pour détecter peut-être les variants préoccupants. Donc, c'est une bonne question. Je pense que je peux vous dire à l'instant, c'est quelque chose que les décideurs continuent à considérer dans le contexte de dire, OK, si on continue avec un système de surveillance au Canada, il y a des choses qu'on peut faire à la frontière, mais il y a aussi des choses qu'on peut faire ici au sein du pays. Donc, je pense que c'est vraiment pour, à ce point-là, être capable de détecter un variant préoccupant.
OK, donc je comprends par votre réponse que
Peut-être que tu peux faire une clarification.
Sure.
Ça, est-ce que le changement de politique aux États-Unis est concernant le test avant d'arriver? C'est pas un changement de politique concernant le test aléatoire après l'arrivée.
L'arrivée, oui.
Au Canada, on a déjà éliminé le test avant d'arriver pour les personnes qui sont vaccinées. Maintenant, jusqu'à maintenant, on a maintenu le test pour les personnes qui ne sont pas vaccinées. C'est juste une clarification.
D'accord, merci beaucoup, j'apprécie. Je me demandais également, est-ce que vous avez des données qui indiquent le début d'une nouvelle vague en Nouvelle-Écosse, plus précisément à Halifax? On me dit que les tests des eaux usées démontrent qu'il y aurait une recrudescence de l'activité de la COVID-19.
C'est Dr. Njoo. Merci pour la question. C'est sûr qu'avec la surveillance des eaux usées à travers les pays, qu'il y a peut-être des différences avec l'activité du virus dans des régions différentes du pays. Donc, c'est pas pour moi pour constater et dire définitivement oui, il y a un problème de recrudescence. Et je pense que c'est mieux pour les autorités de la santé publique en Nouvelle-Écosse pour signaler, pour peut-être déclarer s'il y a une recrudescence ou non, parce que c'est eux qui sont sur le terrain plus que moi. Donc, c'est sûr qu'en général, on peut dire que maintenant, on a dépassé, comme on dit, la dernière vague, 6e vague, je pense, à travers le pays. Et normalement, l'activité du virus pendant les étés, au moins au passé, sont diminuées comparé aux hivers. Donc, je pense on est dans une bonne, comme on dit, espace maintenant, situation maintenant, mais c'est toujours important de continuer à surveiller parce qu'on ne sait pas qu'est-ce qui peut-être va se passer en automne et aussi en hiver quand les gens commencent encore à rassembler à l'intérieur.
Okay, Marie Wolf, Canadian Press, go ahead. Marie, you are still muted. Please unmute yourself.
Yeah. Can you hear me now? Dr. Tam, I just wondered if you could clarify something you said about monkeypox earlier, where you said that NACI recommends a single dose for people with high-risk exposures, and then you said that possibly they should have a vaccine 4 days within exposure. But how will people know what a high-risk exposure is? And could you just clarify what the actual advice is and how whether people should rush to get a vaccination? Because I think this is something that people are not entirely clear what a high-risk exposure is.
Thank you for that question. And I think we are providing some of that information on our website. So this virus is transmitted, as far as we know, we're still collecting information, mainly through close physical contact. So someone who has been in contact skin to skin or a ulcer or something with skin or the mucous membranes of a person infected through some of the intimate sexual contacts is very close, as you can potentially envisage, and also with direct contact with objects like bed linen and blankets or such of contaminated with the bodily fluids or the scab of someone who is infected. And also we're looking at the potential risk via respiratory route. I think respiratory droplet infection through close contact is certainly possible. I think more is being looked at in terms of aerosols, but we know that so far it's really the transmission seems to be limited to that kind of close contact. So by high risk, if you think it more simplistically, are really people who've had these intimate contacts or household contacts, or maybe a healthcare worker who's been working without appropriate personal protective equipment at the time. And the NACI recommendation is for the vaccine, one dose to be offered to someone who knows that they've been in contact with a case, or they've been in a high-risk exposure setting. And those are the ones that are being communicated at the local level from local public health. And they are working with the businesses or settings where cases have occurred to try and contact clients and people who visited those settings. And that's happening, for example, right now in Montreal. They're also offering the vaccine to gay bisexual men who have sex with men who have had multiple partners in the last 2 weeks. So that's a bit more precision or detail. But for the general population, the risk at the present time is low. But what we want to do is to prevent further transmission, particularly to people at highest risk, such as pregnant women, younger children, and those who are immunocompromised.
Thank you for that. Could I ask you a similar question to some of my colleagues about restrictions on travel, including random testing for COVID at airports and vaccine mandates? I wasn't entirely clear from your previous replies what your view is and whether you thought that circumstances are right now to relax travel rules and mandates. And if you feel that they are not, the time is not right, what is the scientific rationale for maintaining them?
Yeah, so I think I'm going to essentially repeat what I've just said, but let's just tackle the mandatory random testing at the moment. So the mandatory random testing is set up as part of our monitoring and detection of the viruses and the variants of concern. We don't test everyone. We test a percentage of the incoming travelers. There's tens of thousands of people coming in a day. We do a randomized sample to select people coming from different areas of the world and are able to detect variants of concern, including BA4, BA5, where it's emerging from. And that acts as an early warning system. So I think that has to be sort of separated from, the other objectives. Is that clear? I'm not sure if you have a question on that first.
I've already cut her off, so we're moving on to the next person. Olivier Ferrand-Boisé from TVA.
Oui, bonjour. Hi. Okay, can you hear me? Yes?
We can. Go ahead.
OK, merci. Je vais juste revenir sur la variole du singe, un peu sur les chiffres, les statistiques. Donc, la semaine dernière, vendredi, on était à 71 cas au Québec. C'était le double la semaine précédente, donc on voyait que ça montait rapidement. Aujourd'hui, on est à 98, encore une hausse, mais ça semble, disons, peut-être moins abrupt comme courbe. Est-ce que vous croyez que c'est dû notamment à la prévention et à la vaccination qui a été mise de l'avant depuis? Est-ce que ça pourrait avoir un impact? Et qu'est-ce que ça vous dit pour la suite des choses?
C'est Dr. Njoo. Merci pour la question. Je pense que, honnêtement, c'est trop tôt pour faire des conclusions. Je pense que les autorités à l'échelle locale à Montréal, mais aussi avec la province de Québec, ils continuent avec leurs efforts. C'est plusieurs comme volets, on peut dire. C'est une question de travailler étroitement avec les communautés à risque, sensibiliser, fournir les renseignements pour pour les gens, OK, si on a peut-être une contact étroite ou peut-être on a un plaie ou une éruption cutanée, c'est très important de faire un suivi avec une fourniture de soins de santé. Ça, c'est très important. Aussi, peut-être pour prévenir les contacts au futur si on est à risque. Ça, c'est quelque chose d'important. Et donc, finalement, l'utilisation des vaccins. C'est intéressant, les vaccins ont été développés pour la variole, mais maintenant, c'est la première fois qu'on utilise pour la variole simienne. Donc, c'est important aussi d'évaluer c'est quoi l'efficacité des vaccins, mais c'est une autre, comme on dit, un autre outil. Et les autorités, je pense que je comprends à Montréal, utilisent avec une approche très, comme on dit, flexible, stratégique. C'est sûr, on offre le vaccin aux contacts étroits qui sont identifiés, mais il y a aussi plusieurs peut-être endroits ou événements avec beaucoup de contacts entre peut-être un cas confirmé et des autres contacts anonymes. Donc, c'est très important. Je pense que les autorités continuent à offrir les vaccins en général aux personnes qui étaient là peut-être un certain endroit ou un certain événement pendant un bout de temps pour leur offrir le vaccin pour peut-être les protéger post-exposition le plus tôt possible. Donc, on verra dans les jours et semaines à venir c'est quoi l'évolution pour la courbe épidémique au Québec, mais aussi à travers le pays.
OK, merci. Et poursuivre, je dirais un peu dans la même veine que mes collègues un peu plus tôt. On entendait le Dr Tam dire plutôt que, 2 doses contre le variant Omicron, c'est à peu près 20% de protection. La semaine dernière, je vous demandais, Dr Njoo, qu'est-ce qui justifiait scientifiquement qu'on maintienne les mandats de vaccination pour les fonctionnaires fédéraux, dont certains sont en télétravail. Alors, je me demandais maintenant, vous me disiez que c'était une décision donc du politique, du gouvernement. Vous aviez vos recommandations et le politique décidait qu'est-ce qu'il en faisait avec. Donc, ma question, c'est quoi votre recommandation et est-ce que vous jugez que le maintien de cette obligation vaccinale-là va dans le même sens que votre recommandation?
Moi, je comprends. Merci pour la question. Je comprends que les décideurs, le gouvernement est encore en train de considérer tous les facteurs, les options. Pour Dr Tam et moi et aussi les autres experts à l'agence, on continue à fournir l'information scientifique, les données probantes, mais on sait que c'est d'informations sont un facteur à considérer, mais comme Dr Tam et moi on a constaté, c'est un travail difficile pour les décideurs parce que c'est pas seulement une question pour les données probantes scientifiques, il y a aussi des autres considérations. Comme j'avais déjà constaté, idéalement, si on veut augmenter la couverture vaccinale, c'est toujours une question de sensibiliser à la population générale, fournir les renseignements pour tout le monde peut prendre une décision éclairée pour être à jour, à date avec leur vaccination, si c'est 2, 3 doses, peut-être même pour les personnes plus âgées, on recommande même une 4e dose. Mais avec une politique, c'est sûr qu'il y a des autres facteurs pour les décideurs, à part des facteurs seulement scientifiques.
Okay, thank you. Next is Adam Miller from CBC News. Go ahead.
Hi there, and thanks for taking my questions. I wanted to ask about testing around monkeypox and, how widespread is Canada's testing strategy for monkeypox? And are we doing any surveillance testing in the community to find asymptomatic cases, or are cases only getting tested after patients present with symptoms?
Thank you for that question. And so for the most part, of course, we're learning all the time about this virus, which we haven't seen outside of the African countries. There's a very significant clinical feature, which is that of skin lesions. So right now, with the dissemination of information to clinicians, they're watching out for rashes and, of course, clinical history of contacts. But they are testing quite a lot of people who are actually testing negative for monkeypox, but positive for other things. So that's one way of casting the net somewhat wide in the front lines of public health. And some of these individuals who are tested actually had very minimal skin lesions, but they are still being tested, and we are finding other causes. The other thing is we are looking at some of the other surveillance systems and through sexual health clinics as well to test more widely. But we are, of course, still looking at new platforms like wastewater and other surveillance systems to see if they can be helpful as well. From a more research perspective, I would say, or epidemiologic study, we are trying to see if there's any way of casting the net wider to look at antibody levels in different populations as well. But right now, I think it's the astute clinician on the front lines who are using a fairly low threshold to test people who may have a rash. This is not like COVID, of course. It's very difficult. Many people have very non-distinct symptoms, but the rash is definitely a clue in this case.
Yeah. It's Dr. Njoo. The only other point I would add is to say with respect to the testing, as you know, initially all of the initial samples were sent to our National Microbiology Laboratory in Winnipeg for that sort of determination, confirmation of what we call lab diagnosis. But the lab in Winnipeg has been working very closely with the provincial labs across the country, and right now is pushing out what I would call technology transfer, so that provincial labs, let's say for example in Quebec and others, will be able, and I think at the present time are already capable of doing their own testing. There's certainly a period in which there might be, quote, quality assurance, confirmation by the NML, but at a certain point in time, certainly the provinces, territories, with the laboratories will be able to do their own testing, which would also help in terms of turnaround times. It would help clinicians and others in terms of more quickly being able to, manage cases and contacts and so on. So that's another thing that we're doing at the national level. Thank you.
Follow up, Adam?
Okay, great. That was going to be my next question, is just what's being done to try to address that backlog. Are we any closer to finding the source of the monkeypox outbreak in Quebec and other provinces? Like, I know contact tracing is tough in some of these networks, but, Quebec especially has seen such a dramatic rise in cases in the past, couple of weeks. Are we any closer to figuring out the source of that and what exactly was driving such a high number there as opposed to other provinces?
Yes, so I think the genetic analysis is showing that our current outbreak is connected to the international one, at least from a genomics perspective. So we're part of that bigger picture. There are certain settings, the local public health unit thinks what might be, I guess the term is somewhat these mini super spreading events where there was a lot of close contact, including sexual contact. So those details are at the local level, and they are working with those establishments, but there isn't maybe a singular event. There may be a few of them that could have initiated some of the change of transmission in Canada. I think some of the initial increase in cases, of course, represents some of the retrospective acquisition, sort of data. And we're looking at the usual I think the local authorities are trying to plot that epidemic curve to go back to, well, what is the initial date of the first case? So that is still being investigated, but there are certain settings, and that's why NACI is also recommending that a vaccine could be offered, not just because contact tracing is very difficult. Some of the contacts cannot be easily traced. And so using these settings-based approaches, we will be able to move faster with stopping chains of transmission. But I haven't heard of a singular event as such, but really a social network, if you like, of clustering at the moment.
Okay, I only have two people left on my list. Let's try and squeeze them in the next couple of minutes. Pierre Saint-Arnaud de La Presse Canadienne.
Oui, bonjour. Vous m'entendez bien, Dr. Njoo?
Oui.
J'ai deux questions qui sont quand même très simples. Est-ce que, ça va être court, est-ce qu'on a un chiffre ou une idée à peu près du nombre de cas suspects qui s'ajoutent aux cas confirmés?
Vous parlez de la variole simienne?
Oui, exactement.
OK. Non, parce que c'est vraiment une question à l'échelle maintenant des provinces et territoires. Je pense que le Québec est toujours en quart d'avoir les cas peut-être suspects et maintenant le Québec est capable de aussi faire le dépistage laboratoire. Donc, je pense que c'est une question de toujours suivre la situation au Québec et c'est sûr. Qu'est-ce qu'on voit avec les derniers jours? Il y a eu une augmentation et on espère qu'avec peut-être la stratégie, avec le contenu de suivi des contacts, mais aussi avec l'offre des vaccins peut-être dans les endroits où c'est des événements peut-être à haut risque, ça va avoir un impact sur la courbe épidémique.
Ma deuxième question, c'est au tout début de l'épidémie, on disait que le Canada avait une quantité limitée de doses de vaccins. Là, je me rappelle qu'on avait dit qu'on ne pouvait pas dire combien pour des raisons de sécurité, là, mais étant donné que l'éclosion s'étend, se répand, est-ce qu'on a modifié ça? Est-ce qu'on a ajouté des doses de vaccins? Est-ce qu'on est allé en chercher quelque part ou on est toujours sur le même stade qui est quand même limité?
Bon, merci pour la question. Comme je pense avec notre note d'allocation, le gouvernement du Canada est encore en train de travailler avec les fabricants pour procurer d'autres vaccins. Mais je peux vous dire aussi que oui, on n'a pas commandé une quantité illimitée. L'approvisionnement, c'est très important et aussi garder toujours une possibilité d'un événement avec la variole, un événement biologique avec la variole, mais avec qu'est-ce qui se passe actuellement. Je pense au Québec, mais aussi ça commence aussi en Ontario. On a eu des bonnes discussions avec nos homologues du Québec et aussi avec l'Ontario. Et à l'échelle fédérale, ici à l'agence, on est d'accord avec leur stratégie d'offrir les vaccins, pas seulement aux contacts bien identifiés des cas confirmés, mais aussi, comme on a déjà constaté, dans peut-être les endroits avec les événements liés avec peut-être un risque élevé de peut-être exposition des autres. Donc, je pense qu'on est ouvert, mais il faut aussi, comme on dit, gérer les attentes parce que c'est sûr et on continue à regarder comment la situation évolue parce que, en fin de compte, c'est sûr, on n'a pas une quantité illimitée de vaccins, mais je pense que si on utilise, comme on dit, avec une bonne approche stratégique, avec prudence, peut-être pour refroidir, si c'est possible maintenant, l'éclosion, parce que c'est peut-être seulement le début, on peut-être une meilleure chance de peut-être éviter l'établissement de variole simienne ici au Canada.
Okay, last but not least, Raisa Patel, Toronto Star. Go ahead. Please unmute yourself, Raisa.
Can you hear me now?
We can. Go ahead.
Yes.
Okay, thank you. I wanted to go back to random testing at airports. You know, from the end of February until the end of May, just under 3% of all random COVID tests at airports came back positive. I mean, that's still more than 8,000 positive tests. So does that figure signal to you that random testing is still a necessary measure at airports specifically? Is that a significant number?
Yeah, I think the random testing is not to detect every case. It's there to provide an early warning system for variants of concern. And you've got great numbers. I'm very impressed that you're so up to date. I think we do post them on our website. But yeah, I mean, 3 out of 100, tested are positive. So we can trend those as well. And when the global epidemic curve goes up, and as you can imagine, some of the positivity rate goes up with the Omicron wave, and it's may be coming down. But that's quite just a message alone that travelers, wherever you're coming from, 3 out of 100 of people coming across may be positive. So those statistics are important for trending measures, but really the early warning on variants is important. And for that, it's not just the numbers of tests, it's the stratification, making sure we get samples from people who are arriving from different areas of the world. Most of them, of course, do come through the biggest airports. And so we focus some of the sampling accordingly so that it gives us a robust estimate, and the confidence intervals are such that we can use those statistics more effectively. So the calculations for the number of tests being done at a given time is based on statistical analysis of whether we will have a good chance of picking up variants of concern. So we believe that at the moment, the sampling frame is such that we can, and we have been able to trend some of the incoming signals, for example, for BA4 and 5.
And just to go back to vaccine mandates for travel for a moment, we keep hearing from politicians that they're following the science on that requirement. But when it comes to that science, which is your jurisdiction, what metrics specifically are you looking at to make that determination that mandates are no longer needed? What figures are you looking at? What kinds of numbers or thresholds would signal that we don't need to have those federal mandates anymore?
Yes, so it's a complex decision-making process, and the data forms one really key foundational input. And I think right now, what we're seeing, even though the cases and trends are still fairly high, that there is epidemiologically in Canada, things are going in the right direction. So that's one thing. I mean, I'm not going to give you the number of cases or the number of hospitalizations a day, because that's really quite complicated. Whether the health system is able to cope at one end of the country to the other is actually quite different. And so, but we do have to look at healthcare system capacity and the hospitalizations, and they are trending down. So that is important. And we can't just calculate how many beds are occupied per day. That would not be a reasonable way of looking at things, but still a trend. And the talking to jurisdictions, making sure that their systems are coping. Of course, there's lots of backlogs and stuff, but in terms of at least the COVID hospitalization is trending down. We, at least for the international data, have to look at the world and the global data and what's happening in the United States, for example. And again, most trends are coming down, which is good news, and that we convey to decision makers. Of course, there's uncertainty into the future as to when the next wave might come, and certainly getting ready for the fall. So when they then make the decisions and we say, well, the global trend is looking better, and some of the testing that we're doing at the moment, we will take into account that mandatory random testing and its percentage. And so these trends are all moving in the right direction. So it's not a threshold or exact number. The other thing, of course, is the vaccine coverage levels, which has been remarkable for the first 2 doses. And for the booster dose, it is less than 50% still of the total population, but quite good in the highest risk groups. So they will take that into account. So there is a gap. There is some ways to go for maybe improving on that 3rd dose. And so they will look at that and take that into account. But still, I still think we're doing pretty well. And so that's the type of context that upon which the other considerations for policy making has to take place. And but I do know that when decision makers are having some of these difficult debates, they do have one thing in mind, which is reducing deaths, reducing long-term outcomes. And so they are taking it very seriously. It's not an easy decision, but I think some of the conditions and the epidemiologic parameters are looking quite good at this point.
Thank you, Dr. Tam, and thank you, Dr. Njoo. I appreciate you giving us a few extra minutes today because we did have a lot of people on the line, lots of interest as usual. That concludes today's press conference. Everybody have a great rest of your Friday and a good weekend. Merci à tous.
Thank you.
Thank you.
Have a good weekend. Bon fin de semaine.